Welcome to EM Rapid 2024. So, today we are going to discuss about two syndromes, that is SIDS and BRUE. Coming to the first one, that is SIDS. SIDS means sudden infant death syndrome. So, as the name suggests, it will be the sudden demise of the infant without an actual pathological cause. We will go to the definition, that is the unexpected death of an infant under 1 year of age, which no pathological cause can be determined by the examination of the either death scene or the history and also of the autopsy. So, SIDS is the major cause for death of infants between the age of 1 month to 1 year. And coming to the epidemiology of the SIDS, most commonly the peak age of death is between 2 to 4 months and mostly seen among boys, and mothers of SIDS victims are less than 20 years of age and mostly unwed and use drug addicts and have history of very few perinatal and postpartum visits and those who are overweight. And these are mostly seen in African Americans and Native Americans and also among lower socio-economic groups. Coming to the risk factors for SIDS, the risk factors include low birth weight and prematurity, and the next one is the most important, that is the prone sleep position of the infant. So, because of the prone sleep position, the child will be prone, and this causes rebreathing of the expired air, and which will cause hypercarbia. Then also there will be inhibition of heat loss that there may exacerbating the hyperthermia. As the patient, if the child is in supine position, the infant is in supine position, it will cause increased heat loss. That is been inhibited here. And the next problem about the prone sleep position is that as the child is having a poor strength in the tone of the neck muscles, that will also cause inability for the child to roll over. Then other causes include bed sharing and sleeping in other positions rather than the crib. Then also other problem associated with the risk factor associated with the SIDS is the swaddling of the baby, that is the baby being kept inside a blanket. So, coming to the pathophysiology, we have a triple risk theory for SIDS, that is infants' underlying vulnerability and the critical period of development and exogenic stressors. So, coming to the genetic, that is the we can find that there is a polymorphism of the interleukin 10 gene, and infants are more likely to have apnea, sustained desaturation and poor ventilatory conditions, that are the infants' underlying vulnerability. And coming to the period of development, that is the period of development, then pre and perinatal nicotine exposure to the children, that is because of the exogenous stressors which will cause blunting of the ventilatory response to hypercapnia and reduce the central respiratory chemoreception. So, this is the pathophysiology, that is infants exogenous stressors, infants underlying vulnerability, then also critical period of developments, that is the main cause for the pathophysiology. And coming to the management, we have to look how the child is presented to the ER. If the child is presented very late, that is having a significantly reduced core temperature with pH less than 6 and infants with rigor mortis and livedo reticularis, so the chances of bringing back the baby are very less, and so these babies should not be resuscitated. The main things we have to do following the bringing of a sudden infant death is we have to obtain a good history, that is complete description of the circumstances the caretakers involved, and also the perinatal and birth history, and maternal family history of any miscarriages or infant deaths, then family history of any diseases, metabolic diseases. And also we have to look for documentation about the child's sleep position, sleep location, and the last time when the baby was seen alive, and also the position where the child was found. And we have to do a complete physical examination following history taking, that may show any child signs of child abuse, that is traumas like facial bruising, petechiae, blood in the nose or mouth, and also we the main thing we have to do again is the about the death summary. Here, as the child was brought in a condition where actual cause is not known, so we cannot write the actual cause. So we will have to do the forms, but the cause of death should be done only after the police investigation. The next one is BRUE, that is brief resolved unexplained events. As the name suggests, the child will be normal when being brought to the ER, but the child had a history of a brief history of unexplained event which was resolved within 1 minute. Brief means 1 minute, and brief event which occur in infants less than 1 year. So we will go ahead with the definition. A brief unexplained event in infants consisting of some of the features that include cyanosis or pallor, then absent or decreased or irregular breathing along with marked change in tone of the baby, that is hyper or hypotonia, and altered level of consciousness. So we will once again go ahead with the definition. BRUE means a brief period of unexplained event which occur in infants less than 1 year of age. The unexplained events include change in color, that is cyanosis or pallor, with absent, irregular or abnormal decreased breathing or altered consciousness, or marked change in the muscle tone, that is hyper or hypotonia. So following the event, the child must return to the normal state to call it a BRUE, that is with a normal reassuring history and physical examination also. The next definition is for apparent life threatening event. This was the earlier used term for the BRUE, that was a crude term and not so well defined. That is, the definition is an episode that is frightening to the caregiver and also involves some combination of apnea, color change, and also changes in muscle tone and choking and gagging. So about the pathophysiology and event classification. So the BRUE can be either a normal or abnormal event. Mostly we won't be seeing what is the cause, as the caregiver or caretaker will be telling about the event. So this can be a normal event or pathological event. So coming to the some of the events that our caretakers will be telling us, that is like a abnormal breathing, that can be either periodic breathing or apneas. So periodic breathing are the cyclic periods of rapid breathing interposed with respiratory pauses that may be frightening to the caretakers. Then the next one will be the apnea. The apnea can be 3 types, that is central apnea, obstructive apnea, or mixed apnea. The central apnea is due to the disruption of the central respiratory system. Mostly the causes for the central apnea include traumatic brain injury and disorders like bacterial infections and respiratory diseases like bronchiolitis and pertussis. The next one will be obstructive apnea, that is due to occluded airway, which is most commonly seen in upper and lower respiratory infections and also in cases of dysphagia and GERDs. The next one will be mixed apnea. So the other one which most commonly seen in premature babies is the apnea of prematurity. So the next one, changes also seen in infant's color, that can be normal or pathologic. The normal one include acrocyanosis and plethoric skin color, and abnormal include central cyanosis. Then change in muscle tone, that can be because of any GERDs or else because of seizures. Then altered level of consciousness can be normal, that is like immature nervous system or loss of consciousness after a breath holding spell by the babies, or else it can be an abnormal event like seizure, hypoglycemia or hypoxemia. So for the BRUE, we have multiple differential diagnosis. Some can be common causes for the BRUE, then other are some will be less common but more serious pathologies. And the most common benign explanations include gastroesophageal reflux diseases, vomiting episodes, then there will be like upper respiratory infections, pertussis, and coughing or choking episodes, periodic breathing, oral dysphagia or breath holding spells. These are the most common DDs, and which are the most common like event which of BRUE. BRUE as such is not a diagnosis. So other common serious pathology involving the BRUE condition is like seizure, infantile spasm or lower respiratory infections, and laryngotracheomalacia, and also in cases of child abuse, inflicted injuries and poisoning cases. Less common but serious injuries include tracheoesophageal fistulas, arrhythmias, then bacterial infections and metabolic diseases. So we will go ahead with the diagnosis, classification and management of the BRUE patients. So initially we will have to diagnose the child as a BRUE event or not a BRUE event. So for diagnosis, the condition should be met, as the child should be less than 1 year of age and the event should be a brief event less than 1 minute. And if the patient is having additional symptoms above the same, it should be diagnosed as not an BRUE event. Or if the patient is in less than 1 year of age with a brief event less than 1 minute, we have to look for the other conditions meeting BRUE, that is cyanosis or pallor or abnormal, absent or decreased breathing, or marked change in muscle tone or altered level of consciousness. If these are present, one or more of the following is present, then we have to look forward for the history and physical examination. And if no other explanation is found, we will diagnose the event as a BRUE, that is brief resolved unexplained event is made. And further, after diagnosing of BRUE, we will classify the BRUE, that is for higher risk or lower risk. If the patient is having family history of sudden cardiac death or feeding or respiratory problems, we will classify the child in a higher risk patient. Or if the patient is not having any other problems, we will apply a risk stratification, that is age greater than 60 days with a gestation like born after 32 weeks of gestation, and corrected gestation age should be greater than 45 weeks, and no CPR was initiated by the caregiver, like the event lasting less than 1 minute with the that is being the first event. We will classify the child into a lower risk category. So we will manage the patients of lower risk category by multiple things that we should do, we may do, we should not do, and we need not do. The main things that we should do for lower risk patients are, we have to support the caregivers and we have to involve them in our decision making events, and we have to guide them in evaluation, disposition and follow up. And following it, we have to give them a CPR training course which will enhance their which will relieve their fears. Then the things that we may do include obtaining a 12-lead ECG, and also we can send for a pertussis testing that can cause pertussis can cause BRUE. Then we can also monitor the patients with continuous pulse oximetry also observing the patient. That is the things that we may do. The things that we need not do include blood glucose analysis, urine analysis, viral respiratory test, viral respiratory panels, then serum lactic acids, evaluation for anemia or neuroimaging, or admission of the patient. That we need not do. The things that we should not do include obtaining total WBC count, CSF urine cultures, then ECGs, then EEGs, other blood gas analysis, then including treatment prescribing acid suppression therapy and anti-epileptic medications. So, other one is diagnosing and treatment of the high risk category patients. The high risk category patients should be admitted, and this patient should be evaluated thoroughly, including laboratory and radiological evaluation. And for the same, premature infants, infants less than 2 months of old, infants with cyanosis, and those with chronic medical conditions should will be that the highest risk of recurrence, and they should be closely monitored. And BRUE or ALT is not does not have the increased risk of sudden infant syndrome. This should be maintained in our minds, and we should be thinking about the same in all events when some child is being brought with an ALT or BRUE event. That's it regarding the SIDS and BRUE. Thank you.